Hello everyone, hope you're doing well. Welcome to the second video slash question and welcome to my channel. Before we begin, I'd just like to say do give a like to this video and subscribe, and let's just move on to the question. Question number 2, drug interactions. A 65-year-old man with a history of atrial fibrillation is being treated with warfarin for stroke prevention. His INR has been stable for the past several months. He recently began drinking grapefruit juice daily after hearing it has health benefits. 2 weeks later, he presents with easy bruising and bleeding gums. Laboratory studies reveal a prothrombin time of 17 seconds, the normal being 10 to 15, an activated partial thromboplastin time of 45 seconds, the normal being within 25 to 40 seconds, and an international normalized ratio of 4.5, the normal being around 1, a bleeding time of 3 minutes, and normal bleeding time being within 2 to 7 minutes. Which of the following best explains the mechanism behind this patient's current condition? Option A, induction of hepatic cytochrome P450 enzymes leading to increased warfarin metabolism. Option B, inhibition of hepatic cytochrome P450 enzymes leading to decreased warfarin metabolism. Option C, increased renal clearance of warfarin. Option D, displacement of warfarin from plasma protein binding sites. Or option E, increased vitamin K absorption from the diet. I'll give you a few moments to answer this question. Alright, if you picked option B, inhibition of hepatic cytochrome P450 enzymes leading to decreased warfarin metabolism, you'd be correct. Let's go into an explanation as to why. Now, when a patient drinks grapefruit juice, it is ingested, obviously, and absorbed within the small intestine, and then sent to the liver via the portal vein system. Once in the liver, it's metabolized by the hepatocytes. Now, if we go down and look at the histology of an hepatocyte, just a quick, very brief histology. You have the nucleus, and continuous with the nuclear envelope is the rough endoplasmic reticulum, which is responsible for protein processing. And connected to the RER, you have the SER, the smooth endoplasmic reticulum. This smooth endoplasmic reticulum hosts the cytochrome P450 system. It's a heme-based enzyme that essentially oxidizes drugs using oxygen and NADPH. Nicotine dinucleotide phosphate. Now, once these drugs are oxidized, like warfarin for instance, they become more water soluble and they often lose their effects. Or you can convert a prodrug into a drug in the body. Now, the cytochrome P450 system has a lot of inducers and inhibitors, and in this case, grapefruit juice is actually an inhibitor of the cytochrome P450 system, and warfarin is, you have to remember, is a substrate of the cytochrome P450 system. So there's a really quick mnemonic to memorize the inhibitors. Sick faces come when I am really drinking grapefruit juice. Now, if you look at the underlined blue lines, we'll go through the inhibitors real quickly. Sodium valproate, isoniazid, cimetidine, ketoconazole, fluconazole, acute alcohol overuse, chloramphenicol, erythromycin, sulfonamides, ciprofloxacin, omeprazole, amiodarone, ritonavir, and then finally grapefruit juice. That's actually an inhibitor of the cytochrome P450 system. So if warfarin is normally metabolized by the CYP450 system and turned into its metabolites and then hepatically excreted, you can imagine that a soldier, right, as mentioned as drawn in Sketchy, right, a warfare time soldier would become retired once it's turned into a metabolite and no longer exerts its effects. But if you inhibit the CYP450 system, all of a sudden none of your soldiers are retiring. In other words, warfarin starts to accumulate in the body. And so you actually go into warfarin overtoxicity. So here we see a lot of soldiers, and the patient, as mentioned in the vignette, had bleeding gums. That's because the coagulation system in the body is no longer working anymore. In fact, there is a anticoagulant effect that's occurring due to an increased amount of warfarin in the body. Now, what does warfarin do? Quite briefly, warfarin inhibits vitamin K epioxide reductase. I've drawn a little diagram down below, but to remember which clotting factors are affected, just remember the mnemonic 2 plus 7 equals 9, then 10. That's how I remember the clotting factors involved in vitamin K carboxylation. And so warfarin has a anticoagulant effect. And you also have to remember protein C and S are also involved in the carboxylation that involves vitamin K. So just real quickly, reduced vitamin K is used by gamma carboxylase to convert the clotting factors 2, 7, 9, and 10, as well as protein C and S, and basically to attach gamma carboxylate groups to these clotting factors. And what that does basically is it allows the positive calcium ions in the blood to bind to these negatively charged groups and basically allows a calcium bridge. So the clotting factors are on one side, the calcium ions attach to these carboxylate groups and also attach to the negative phospholipid surface of the platelets. So one could imagine a calcium ion bridge here, which is connecting to the clotting factor with its negatively charged carboxylate group, and also attaching to the negatively charged phospholipid group on platelets. So you have this little mini bridge that's now forming, and this is not just occurring in one with only a few molecules, this is occurring all over. So one could imagine how a coagulation cascade could occur. And when vitamin K is used to carboxylate these clotting factors, it's then oxidized, and vitamin K epioxide reductase, this little enzyme over here, VKOR, is used to turn the oxidized vitamin K back into the reduced form. And this is where warfarin actually exerts its negative effects. Warfarin actually inhibits this enzyme and prevents the oxidation, it prevents the reduction of vitamin K, so it can't be reused. Hopefully that explains option B. Now, as to why the rest of the option choices are wrong. Option A, induction of the hepatic cytochrome P450 enzymes leading to increased warfarin metabolism. This is wrong because instead of the patient presenting with an increased INR, the patient should be presenting with a decreased INR. So this would mean that the patient would become prothrombotic. In other words, they might develop a stroke. Just a quick example. Imagine if a patient is taking warfarin chronically, like in this patient, to prevent a stroke, and it's found out that he's developed TB. Now, TB's drug regimen includes rifampin, a CYP450 inducer. This means that CYP450 enzymes are way overproduced, and that basically metabolizes more of the warfarin, decreasing the warfarin concentration, meaning there isn't as much of an anticoagulant effect. In other words, there is a procoagulant effect. Now, that because there's a procoagulant effect, the patient is more prone to procoagulant diseases like a stroke or pulmonary embolism. So, a patient's taking warfarin for a long time, suddenly develops TB, starts his TB drug regimen, and all of a sudden develops a stroke 1 to 2 weeks later. That would be an induction of the hepatic cytochrome P450 system. So the opposite of what we see in this vignette. Option C, increased renal clearance of warfarin. Warfarin is mainly metabolized in the liver, so renal excretion has nothing to do with this. D, displacement of warfarin from plasma protein binding sites. Although tempting, displacement occurs transiently and is associated with only a few drugs like sodium valproate and TMP-SMX or trimethoprim sulfamethoxazole. And some sources also state that salicylates at high doses can also displace warfarin from plasma protein binding sites. And finally, option E, vitamin K. If warfarin is inhibiting vitamin K, increased vitamin K would actually be beneficial for this patient, or actually would reverse what warfarin is supposed to do. So vitamin K reverses the warfarin effect and therefore decreases INR. So this can't be the answer either. All right, thank you for listening.